This lecture is about hypertension, and I think as nurses, we all recognize how important it is that we understand this thoroughly and are able to competently manage and treat hypertension. So I think with the conversation of hypertension, you have to talk about what blood pressure is. And this is a review that it is the force in arterial structures created by an interplay of flow, volume, and constriction. So high blood pressure or hypertension has been defined by determining the levels of blood pressure that cause target organ damage, morbidity, and mortality as arterial flow is delivered. You know, I think back about when I went through nursing school myself, really much more concentrated on the constriction of the arterial vessels as being the problem with high blood pressure. But blood pressure is really that, the circulating volume and the structures themselves and the integrity of them. So as you think about hypertension, I think really considering these helps us be better providers when we think about what is the process of blood pressure and then what creates hypertension. And unfortunately, we don't know what creates 95% of hypertension, which is also called primary or essential hypertension. The other 5% or secondary hypertension is caused by either structural, circulatory, or chemical abnormalities. I think it's staggering to think that 1/3 of adult Americans have hypertension, and only about half of those, slightly over half, 51% in the general population, control their hypertension. So when you think of the significant risk factors that correspond with high blood pressure, coronary artery disease, heart failure, stroke, peripheral artery disease, kidney disease, and retinopathy, you realize the impact of the public health threat. And this should be a top priority of all providers to make an impact, to make these numbers be reduced. In 2011, the deaths that they recorded directly related to high blood pressure was over 65,000. Indirect deaths were over 377,000. And we'll just talk a little more about incidence and prevalence. We know that systolic hypertension is more prevalent in older adults. More men have high blood pressure until their mid-set 50s. And then about age 55 to 64, men and women are equal. And then after age 74, women are slightly more. Generally, unfortunately, we see lower socioeconomics impacting blood pressure, and we attribute those to a poor diet, stress, and less access to health care. Black African Americans have more hypertension until about age 75. They also have more cardiovascular disease and stroke and renal complications. Enhanced renal sodium reabsorption occurs in about 57% of African Americans, as compared to 27% of other ethnicities. And so we really believe it's that salt sensitivity that does contribute to a higher degree of hypertension in African Americans. But that certainly wouldn't be the only reason. And I think that there's a lot left to be discovered about that. Risk factors, look at those. I mean, and our text does a really good job of drilling down into those risk factors so that you can look at them a little more carefully. And I really like how they look at secondary hypertension and the causes of them. And I want you to go ahead, and I didn't include all that information in today's lecture, but it's in our text, and you do need to understand it and be responsible for it. So those risk factors include obesity, metabolic syndrome, high dietary intake of fat, and a lower intake of potassium, excessive sodium, as we spoke of before, inactivity, obstructive sleep apnea, excessive alcohol intake, smoking, stress. All of those things are associated with the development of hypertension. So again, I cannot reiterate how important it is that we adapt and adopt the idea that prevention, detection, and treatment should be a public health priority. So if you believe that and you're looking at this evidence and you know that a third of the adult patients that walk into your office could possibly have high blood pressure. So what's the pathogenesis behind it? Blood pressure is a product of cardiac output, and you remember from patho, that's heart rate and contractility and circulating volume, and its impact on myocardial stretch. So you've got all three of those components, and then peripheral resistance. So that vascular constriction and compliance or lack of compliance because of the constriction. So it seems as if it would be something, since we do understand the pathogenesis behind it, that we could treat more effectively, but I think you can see that it's very complicated. I just gave you an illustration of an algorithm of how to put contextually what does the normal blood pressure look like previously, and what is the 2017 updated classification system, how we have, through research and evidence and practice, made a shift, and then what does that management look? It's just another example of looking at an algorithm and looking at old data and newer data, and making sure that you're practicing with the best evidence. Physical exam, you would want to obtain a precise blood pressure and heart rate measured in each arm ×2. So what does that mean, a precise blood pressure? What do we do when we bring people into primary care? We make them sit out in the waiting room, and then we rush them in, we weigh them, which causes great distress. We put them in a room, we put them on the table, we don't support their back, their feet aren't flat on the ground. All those things we learned in nursing school. So if you really need to think about the logistics of taking that blood pressure or having the nurse take it correctly. In your physical exam, you want to auscultate carotid and aortic arteries. Fundoscopy is important. I know that as a novice, it is not so easy to do, but finding out if they do have a eye exam annually, and then just keep practicing. It takes a while, okay, but something really overt you can see, but something a little less overt or discreet, it's difficult until you gain practice. You want to look at height and weight ratios and those BMIs, and you want to assess any evidence for end organ impairment or secondary causes for hypertension. And so what guidelines do we currently use? If you're not familiar with JNC8, then you need to become familiar with JNC8. And that's the last expert panel that gave us parameters of looking at blood pressures. And I showed you previously what they were and what they are currently through JNC8. And you can read that evidence, why they made the changes, okay? And I think the biggest thing for me was the numbers went up, and recognized through research that they didn't have to be as tight. And sometimes if the numbers were really low, it was more detrimental, especially in our patients over 60. But the next thing I tell you is guidelines differ slightly. Well, you've already figured that out. There might be 3 expert groups cardiologists, and they'd have different opinions, and their research actually showed some differing information. So it really kind of falls on us. It doesn't really, it really does. Then kinda. You'll make the decision which guidelines you follow, and that's what we get for individual decision making and practice, because there are excellent guidelines that differ. So I just want you to review that information. Diagnostically, we usually look at a urine, CBC, or we need to look at potassium, blood urea nitrogen, serum creatinine, those kidney functions, a fasting blood glucose. You want to know their lipids, if there's any uric acid elevation, serum calcium, and an EKG or ECG to identify left ventricular hypertrophy or any other abnormality, I believe. Differential diagnoses is to exclude the possibility of secondary hypertension, rule out underlying diagnosis that trigger hypertension, and make sure they don't have white coat hypertension. That's an interesting topic, and that has a lot of opinion around it. One of my professors when I was in school said, well, if the white coat makes them nervous, what else in life makes them nervous? Traffic, visiting somebody in the family that causes stress. Are those elevations of blood pressure and stress, should they be treated? I did include a short article written by Dr. Beckman about how to document and code for hypertensive disease. And I think it's worth the read. I think you'll appreciate it as you're learning to code, and you're going to see this so frequently that's one reason I extracted it. Management and referrals. If blood pressure is 180 over 120, to the ER. And if the individual has signs of target organ dysfunction, you want to refer to the ER in light of an elevated blood pressure like that. If hypertension is resistant to therapy, failure of 3 full dose or maximally tolerated antihypertensive drugs, including a diuretic, refer to an MD. You have to be thinking why. There's probably a secondary cause. Non-pharmacologic, lifestyle modifications with regular exercise, loss of weight, tobacco cessation, reduction of daily sodium intake, which is recommended less than 2,300 milligrams a day, that a little bit over 2 grams a day, and moderation of alcohol intake. Then the pharmacologic management, chronic kidney disease and or diabetes, the blood pressure target is slightly less, and you want to look at using an ACE1 or an ARB or alpha receptor blocker as initial treatment. And then look at the nuances for non-black individuals plus or minus diabetes. I just put in this synopsis of thiazide-like diuretic, a calcium channel blocker, ACE or ARB, and then our African American patients, thiazide-like diuretic or calcium channel blocker, ACE or ARB for black individuals. These meds are still considered a mainstay of treatment in the presence of diabetes, regardless of race. Read this next statement. Majority of people require 2 meds for adequate blood pressure control, and it's not very rare that it's 3. They work differently. Again, for non-orthostatic patients whose blood pressures are greater than 160 over 100, diastolic 2-drug therapy is suggested. Follow up in 1 to 4 weeks. I do it sooner for toleration. And if blood pressure is not at goal, may increase the initial drug dose or add a new drug. And monitor that potassium when you're prescribing ACE and ARBs. And just remember that, you know, when you begin to double a med you've started, you don't get double the effect. I've read some places 8-10% effect. So doubling and tripling and maxing out is not the answer. Thank you for your attention.